Okay, just going to give people a few seconds just to get in from the waiting room. Sometimes connections can be a little bit rocky, and particularly when it's Therapy Live. We've got previous. So hello everybody, and thank you for choosing the Rehab Belongs in Advanced Practice session this afternoon. This session is sponsored, well actually it's sponsored by Therapy Live, but what we're going to do is give you a great offer. We've got an unbelievable amount of CPD content on the member site, and as a special offer for today, we're offering attendees the opportunity to upgrade your account to include every Therapy Live video ever recorded. For only £75 instead of the normal £140, you will get a full year's access to the entire library. That's about 300 hours of the best CPD available, and that's on top of any recordings that are being done today. So click the banner below to access this offer. I'm reliably informed that it will be gone tomorrow and it won't come back. So to get to the session today, we've got Tom Flanagan. Tom is an advanced practice physiotherapist in the NHS, specialising in working in an MSK setting. He's got interest in rehab, so much so, and he's also like to find out who else has got an interest in rehab. Tom's put a link in the chat. Please go to his MailChimp site and just fill out the form that's on there just to see who else has got an interest in rehabilitation. But Tom, I will let you take it away, and I will pop off the screen and I will pop back up later on for the Q&A. Over to you, Tom.
Lovely stuff. Thanks, Alistair. So I'm going to click onto screen. Can you give me a shout out if you're...
Just popping back. Tom, I'm not quite sure what happened there. We're going to try and get Tom back. These are the usual fun with Therapy Live. Hopefully, you should be able to get back in. The screen share did work perfectly just before the session started. So we shall see how this goes. But it is Therapy Live, and we'll put emphasis on the live. I'm just going to give Tom a second. See if he can come back. I'll send him a quick message. His MSK physiotherapy work, hence the name of this title. So please don't forget to click the link that is in the chat from Tom to get into his MailChimp. And the man is back, thankfully. Don't know what happened there, Tom.
What happened there, mate?
I don't know.
I was on slide 5.
You finished it, have you?
I finished. That was lovely. Any questions? No, well,
smooth. Do you want to try again?
Yeah, should we try that again? Can you give me a shout out to screen share?
Yeah, I'll give you a shout at the end. Yeah, what you were just saying as you docked off.
Yeah, just let me know if you can see the opening slide, Alistair. Give me a yes if that's cool. Have we got that? Rehab belongs in advanced practice.
We do indeed. Take it away.
Look at us. Please tell me that I haven't just dropped off again.
No, you're good.
We're good. Right. So I'm restarting my timer though. I'm taking that 2 minutes back. I'll try and speed things up though. So thanks for the intro, Alistair. I'm Tom, I'm a physio. I work in an advanced practice role in a community MSK setting. So your usual APP role in MSK. I inject, I arrange imaging, I refer on. I also review and prescribe rehabilitation plans. So jumping in, a little bit of housekeeping to begin with. So this is the overview of today. These are the questions that we're going to try and answer. Just 3 questions, really. But before we talk about those questions, I want to do some housekeeping and talk about some definitions. First of all, advanced practice. What do we mean by that? Well, Health Education England defines advanced practice as clinical practice that is delivered by an experienced, registered health and care practitioner. It's a level of practice characterized by a high degree of autonomy with complex decision making, underpinned by master's level education that encompasses the 4 pillars of advanced practice. That's clinical practice, leadership and management, education, and research. And that's got to be aligned to core capabilities and area specific clinical competence. So that's advanced practice. Specialist, I chucked this in because of a conversation on Twitter during the week. But a specialist is defined as a person who concentrates primarily on a particular subject, highly skilled in a specific or restricted field. And finally, rehabilitation. Rehabilitation means a lot of different things to different people. So I just wanted to touch on this. The World Health Organization define rehab as something that addresses the impact of a health condition on a person's everyday life by optimizing their functioning and reducing their experience of disability. So that's rehab. Just point out the fact that rehab does not necessarily mean exercise. It's a bit more complicated than that, although exercise is clearly very important. So now we've got that out of the way, let's talk about our first question. So I'm a keen advocate for patient-centered rehabilitation. So of course, I think there's a need for APPs to maintain and develop better rehab skills. And thankfully, I don't seem to be alone with that. So in primary care, we know that patients who present with musculoskeletal complaints, we've got data to say that what they want is, first of all, to be heard and then to be given valuable care. That's Rehab 101. So patients want our physios to be good at rehab. Clinicians, you guys listening in, myself included, MSK Reform ran a Twitter poll recently, which demonstrated that there's a want from clinicians to develop rehabilitation skills, as you can see that on the screen now. And so we've got patients, we've got us, and also our MSK service provider colleagues. First of all, T&O. So if we talk about trauma and orthopedic colleagues, they're highly specialized people. They're aware of the data around what works, and they want to focus on that. But sometimes these our colleagues in T&O are faced with a patient who presents to them desperate and asking for help. For example, you might have a 6-year-old person with knee OA. They're not quite ready for a total knee replacement. Nothing else seems to be working. They end up having a scope. We get grumpy. We talk about it at lunch. We go on Twitter and have a little moan. But here's the thing. Rehab might have been the answer for that person earlier. And it's likely that that patient spoke to one of us in their journey. And maybe if we need to take a bit of ownership as physios and APPs to provide better rehab earlier, to prevent T&O being posed this question from a person who just wants help and they feel like they might be able to provide that. So it's likely our T&O colleagues want us to have some specialism in rehab, even into our APP development. Then another colleague in MSK Care is our pain team colleagues. Now, there's a large percentage of patients who end up on a pain team waiting list, and they're usually quite long, right? So there's a lot of these patients who are on that waiting list, even though there's an absence of any significant psychological or sociological challenges. And these people might be better suited to primary care. And it seems to be a big problem for pain clinicians who I've spoken to that are going through triage and referrals. And the problem here is we see these people, we're often the ones who refer in. And again, it's just another stakeholder in MSK Care who probably wants us to continue developing rehab skills even into our APP advanced practice years. The final stakeholders are our managers, our organizations, the leaders in our field. There's lots of investment. So we've got Neil Langridge in Bournemouth, who, if you look at Neil's Twitter page, you can see there's a significant investment in rehab interventions. Laura Grady Gibbs in Dudley, again, promoting significant investment in rehabilitation. And other organizations such as Connect Health, who have a long history, and I was proud to be part of their history in developing good rehab interventions. There's a lot the main stakeholders in MSK care all seem to want advanced practice specialism in rehabilitation. So, is rehab specialism needed in advanced practice? The answer, I'd say, is yes. So, the next question is, where is everyone? It's needed. Is it there? Well, I asked Twitter because all good data comes from Twitter, clearly. And this is what we found. So, very few MSK practitioners feel their colleagues specialize in advanced practice roles in rehabilitation. So, why is that? Why do we have a lack of APPs who are considered specialists in rehabilitation? I find that really, well, I'd say that I'd find it odd, but actually I don't, in all honesty. I think there's lots of reasons, but there's two big ones from my perspective and my reflections. The first one is it seems easier to demonstrate progression with diagnostic skills. You can get a diploma in sonography or traditional extended scope skills like injection therapies. But you can't get a diploma in rehabilitation. So when you're going to evidence your progression, that seems to be a problem and maybe a limitation with people wanting to progress in their career. The second reason, and the one that I'm going to concentrate on here, is rehab's clearly desired, but it's really difficult. Rehab it's hard. Not only because actually when we do a rehab plan, it's difficult, but even getting there in the first instance, we're so occupied by screening and other symptoms that rehab plans are almost a second thought that are overshadowed by anxious screening endeavors for different pathologies. And it's not to say that that's not sensible, but it's a reason why I feel like there's a lack of APs who specialize in rehabilitation. So what do we do? What do we do? What can we change? A recent service evaluation in a community physio department in MSK outpatients showed that less than 30% of their patients have a set goal. So almost 8 out of 10 patients who go to a physiotherapy service don't have a goal set. And for me, I think that that's incredibly bonkers. And the reason, I'm not saying it's easy to set goals, but we want to be useful. I'm pretty sure everyone listening here today wants to be useful at everything they do, particularly those of you who are invested enough to spend your Saturday listening and developing your practice. So we want to be useful. And how do we know if what we have done is useful if we don't define what that looks like? Or to put it a different way, how do we know if what we've done and what we've prescribed for our patient has worked if we haven't defined what that looks like? And to take that one step further, I'd ask the question, can we call a care package rehabilitation if there's not a defined direction of travel? Personally, I'd argue not. And I worry that this lack of direction causes a lot of angst for physios. I think it perpetuates a sense of uselessness. Now, I consider rehabilitation to be the most fulfilling and the most interesting part of my job role. And I think it's because of this. Around about 5-6 years ago, I changed employers. I went from one organization to another one, and there was a different culture surrounding assessment techniques. In my previous role in an MSK out setting, we had these lengthy performers, and there was a need to fill this out. I then went to a different organization, and I found that it was just much easier to listen to my patients. And by listening to my patients more, because I wasn't obsessed with filling out this form and these screening endeavors, it was a lot easier to listen to my patients, and they were quite often telling me what they actually wanted when I let them speak. So I consider rehab to be a really fulfilling part of my role. And I don't think that that's particularly common. And I think that's shown in the polls that we've seen here. But let's compare that perception of uselessness in the absence of defining usefulness. Let's compare that to something different. Let's compare it to imaging or injections. Now, I said at the outset, I work in an APP clinic, um, and I do inject and I do arrange imaging. And for those of you who do it, you'll know what I'm on about. For those of you who don't, you'll probably feel what I'm about to say as well. And that is arranging imaging and doing injection therapies is absolutely class. It's brilliant. It's so, so lovely. I'll see someone who I think imaging's indicated for you. You want imaging. And I think it's going to be really important for your recovery for us to arrange this. And I do that. And I say to my patient, listen, Mr. Neil, yeah, Mr. Neil, um, let's do this. Let's get some imaging done. And I feel great. It feels really good because that person's like, wow, that's really useful. I'm like, yeah, that's really useful. Injections are even more so. I love injecting. It's absolutely brilliant. I tend not to do many because I struggle to find patients who ultimately want it once we've talked about their options. But when I find the right patient and they want it and I think it's going to be good for them, I feel brilliant. It's so useful. You feel so fulfilled. And that's missing in rehab if you don't have it. If you don't have set goals, if you're not defining what usefulness looks like, I worry that that will take its toll on your longevity in a career as a rehab centric clinician. So, my final point on defining success, on goal setting, is if you value rehab skills and you want to keep them central to your practice, and we need you to, right? There's a need for people to stay interested in rehab 15, 20, 30 years into their career. And if you want to be part of that group of people, I strongly suggest you try and make this goal setting habit central to your practice because it makes you feel quite good. So, define success. Let me ask you a question. And I hope the answer to this is yes. Do you care for your patients? Now, I'm talking to my camera and I've got loads of screens up, so I don't even know if I've gone offline again. But assuming that you've heard me, imagine if we were face to face, I'm sure that there'd be lots of nodding heads. Do you care for your patients? Yeah, of course I do, Tom. What are you on about? Of course you do. Do you care for each patient equally? Do you care for every patient equally? Well, if you had asked me this a month ago, maybe a couple of months ago, I would have said, yeah, of course. I'm a nice person, and I like helping my patients. I probably would have felt really annoyed that I was being asked this if I'm being honest. But recently I read something that was kind of uncomfortable actually. It was a book called Live Wired, and it's written by a chap called David Eagleman, who's incredibly fascinating. He's a neuroscientist and does loads of cool stuff. If you're interested in this sort of stuff, it's a good listen, a good read. But in Eagleman's book, he talks about some functional MRI studies looking at empathy. And in these studies, they were put into an fMRI scanner, and everyone was shown a picture of a hand, and this hand was being injured. Now, the fMRI showed a part of the brain heavily linked with empathy lit up. Okay, I'm watching someone get injured, and I feel empathy. And this suggests the fact that this just happens suggests that empathy is not a conscious process. It just happens to us. It's primal. So that was the first study, but later a different study was done. And what they did differently was they had people again put on the scanner, and they were shown another hand that was being injured. But there was a difference this time. And that difference was the image had been given a label. And that label was a different social group to the person in the study. And something really scary happened. The amount of empathy activity changed. So that shows us that it's plausible that I would have less empathy for someone because it's primal, because it's not a conscious process. I would have less empathy for someone who's not part of my social group. Or to put this a different way, if I saw a patient who was wearing a Manchester United shirt, just because they were wearing that shirt and they're part of a different social group, I might arguably have less empathy for them. Now that's oversimplified, but how scary is that? I could care less for a patient simply because I have better taste than them. Yeah, as a Liverpool fan, I think that's clear. For those of you joining from different countries, Manchester United are a football team from the north of England who mattered maybe 9-10 years ago. You would have heard about them a little while back, but yeah, they don't really matter anymore. But on a serious point, empathy is extremely complex. It's primal, and sometimes it has to be harnessed. So why does that matter? Well, it matters because the amount of empathy you have, or to put it a different way, the amount that you care for someone on a subconscious level or on a primal level will change depending on processes outside of your conscious control. Remember, empathy is not a conscious process. It just happens to you. But empathy is extremely and incredibly powerful, not just for our patients, but for us too. And harnessing relationships with your patient, finding something relatable with them might be important, as important for your patient's journey as yours also. Because if you listen to people and you develop relationships, you'll find something in common 9 times out of 10. So let's get to know our patients. Let's be interested in our patients from the second that you meet them. When you go out into the waiting room, find something out about them. You got a little bit of a walk. What did you get up to at the weekend? Have you had a busy morning? Find something cool about them. And I put it to you that if you spend 2 or 3 minutes of your assessment just getting to know your patient, your day will go faster and rehab will start to become more fulfilling. So be interested, but also be cheeky. Now, I've been granted one swear word for this presentation and I'm using it here. So really excited about this. Bear with me. Okay. Some goals are shit. Okay. That was a bit too harsh, actually. Sorry. But some goals are a bit crap. And that's okay. Sometimes it's not, though. Imagine this. You've met a patient, a really cool patient. You know, those really cool patients that you just like, yeah, I feel alive after I've had half an hour of them, and it just feels really cool. Now, this patient, she's so cool. She used to provide swimming lessons for kids with complex needs, and she loved it. But she stopped. Her knee hurt, and she saw a really crappy physio who told her she can't continue to do it. Now, she's only come to you because she's had a flare of her symptoms. And you've had this really cool conversation. You get to know her and you end up at the goals conversation. You start to find out, right, how can I help you? I've got an idea in my head because I know you, I've listened to you. And she says her goal is to go up and down stairs easier. Cool woman, shitty goal. Yeah. I've done it twice. I'll get told off. But cool woman, really crappy goal. Now you know that it's a crap goal because you spent 2 minutes finding out how brilliant she is. But there's good news. You and Mrs. Neal, I don't know where that's come from. You and Mrs. Neal, the good news is you're best friends now. She's your new Bezzy, right? And she's told you, you know that because she's told you your reminder of a son, and she's even given you the recipe to a special rum cake, which is concerning amount of rum. It's basically just rum. It's rum and flour in a glass. But the point is, you're best friends. Now, you've earned the right to be cheeky here. So be cheeky. If your patient seems a bit boring, and by that I mean it doesn't seem to be aligned to their values, ask them why. Ask them why they're lacking ambition. This can be so powerful. And the reason why I say that is because it shows you've listened to your patient. You're selling positivity to them. Imagine being on the other end of that conversation. You met someone who has listened to you so much and they're so interested in your recovery. They're trying to get you more to do more than you thought you could. How cool is that? So a final point on being cheeky is, and a serious point, we have a responsibility to our patients. We know a lot about anatomy and exposure. We know that the body's plastic. We know that it will adapt, and we have a responsibility to open our patients' eyes to that. Because for too long, healthcare and exercise professionals have done the opposite. We need to change that narrative. And if you're not taking the brave move of having that conversation with your patients, you might be letting them down a little bit. So be cheeky, and let your patients know that if we expose in the right way, the body will probably adapt in a positive manner. So one thing left to say that we could do differently, one more change that I could suggest, and that is to do less. Question: who here ever prescribes exercise for no reasons? I imagine there's a few nods. Yeah, sometimes it just happens. I say that because physios, we have this twitch with exercises. You'll be in a room with a patient and you think this person doesn't need exercise. They've got the capacity they need to do this. They're just a bit anxious and they need permission. They need the green light. So you're like, right, I'm not going to prescribe an exercise, but the internal physio is there. And all of a sudden, your arm is just handing over a yellow TheraBand and it just happens and they're walking out. And how did that happen? But there's a culture problem in physio. We tend to give exercise even when we don't really need it. But that point aside, usually exercises are prescribed for good reason, but not all exercises are of equal importance. And if you're good enough to get to the end of a consultation with a set goal, don't ruin it by prescribing too much exercise. If your patient is able to achieve their goal with one thing, and it might not even be exercise, but if they're able to achieve their goal with one exercise, for example, please don't prescribe 3. An example would be if your patient wants to run 5K and they can currently do 2, you might not need a strengthening program. You might just need to give them some reassurance and suggest they gradually increase their distance. And if you're thinking, is Tom asking me to prescribe less exercise? You're almost right. I'm not asking you, I'm begging you to prescribe less exercise. And the reason why is this: an exercise program that includes 3 different exercises will take around 15 minutes to complete if you do 3 sets of 10. 4 exercises, 20 minutes ish. If you're prescribing 6 exercise, you're pushing the 30-minute mark. Now, many of our patients don't exercise at all, yet here we are asking them to do as much exercise as many bodybuilders. It's just not feasible, okay? People want to find the easiest route. The more you prescribe, remember there's that hierarchy of exercise. It's that one that you know is really important to them. Don't chuck in one that is less important, because often it's less important because it's less challenging. And people want to do the easy thing quite often. There's data on this. So if you give them the option to do something easier, they often will, right? Because they don't have time. So focus your patient's energy on the one thing that's going to make a big difference. The more you prescribe, the less likely your patient is to do the one thing that really matters. So there's just a few things that I think we could change to help our patients and to help ourselves more so than anyone else, because there's a need for us to continue developing our rehab skills and continue as rehab therapists. There's a need for that, and we need to do something to make sure that that slide that I showed earlier with the lack of rehab specialist APPs, that's got to change. And there are a few things that I could suggest that we consider that might help. So in summary, bang on time. If you like rehabilitation, you are in luck. Everyone seems to want you to specialize in it. Patients want you to specialize in it. T&O colleagues do. Pain team does. Even your boss does, debatably. All right. But more bosses are starting to. Our leaders are recognizing the need for this. So there are opportunities now, and there's only going to be more with time. Now, if you're already doing these things, the 4 things that I suggest you consider. If you're already doing the things that I've suggested, great. Sorry for wasting half an hour of your time. Slides are nice though, really good. Lots of animations, quite sexy. But if you're not doing these things and you're starting to feel a little bit, feeling the toll of patients coming in to you saying, I'm not better. Well, there's a few things that could help you. Start off by defining what that looks like. That's so powerful. And finally, a bit of shameless self-promotion. If you want to know more about these things and more than a rush 30 minutes with some, mind you, sexy slides, myself and some colleagues are starting to provide some education content on rehabilitation in a community MSK setting. So I work with Martin Coley, who's an advanced practice physio specializing in pain, in a pain team, and also Jack Chew's part of our team as well. If you don't know Jack, he's a little known physio, has a podcast. He's all right. But all joking aside, we're going to do some face-to-face education on MSK later this year. We're really excited about it. We've done a few things that's really quite cool. If you're also interested, there's a link in the chat. I'll pop it in again. Enter your email in that link to know more, and we'll keep you updated.
Fantastic.
Thanks for listening.
Thank you ever so much, Tom. And yeah, some interesting points there. That Jack Chew is an aspiring rehab professional, I think, up and coming.
Band 5.
So yeah, I mean, so many things to pick apart. I mean, obviously, you put a bit of work into those slides, so they did look majestic.
Majestic.
So credit to you on that one, sir. I mean, I'm not really going to wade into the football furore as a Sheffield Wednesday fan. There's not much to chat about these days, so I just sort of keep my head down. But the yellow TheraBand thing, I mean, ooh, you've lost some followers there, I think. On the yellow TheraBand.
Love a yellow TheraBand.
Some really, really interesting points there, and I think some good questions in the chat. I'm going to kick off with sort of one of mine, and it sort of echoes a couple of people's questions around, why, do we think that there's a big focus towards diagnosis and diagnostic, or just diagnosis in a whole in of itself, and less for rehab? Do we think that's a bit of a situation where technology is advancing, and therefore we are, we're seeing new shiny things, and as physios we sort of jump on new things, and therefore that's leading us away from, sort of our core as rehab professionals, because ultimately, remedial gymnasts are sort of one of the foundations of physiotherapy.
Yeah, I guess so, and I think that there's pressures, social pressures. I think it's really easy. It's really difficult to feel like you specialize in rehab because you can't get a diploma for it. And also it's supposed to be our bread and butter. And I really wish that it seemed that way in reality, but it doesn't. So I think that, yeah, it is a problem. And the culture around diagnosis is a problem. Trying to be doctors.
I've popped James up there because I think he's succinctly framed the question a bit better than I did. Are we part of the problem trying to be doctors? Making rehab less valued.
There's this content called rheumatology physio who just keeps pushing these different obscure diagnoses out there.
Jack March. Yeah, different.
Oh, is it? This isn't Jim. Oh, right, okay. Well, that's very confusing.
But yeah, do you think we're part of the problem then, essentially, almost trying to be too over diagnostic, or do you think that's not part of the problem?
I think yes, but we need to look at solutions really. What can we do ourselves to make staying interested in rehab into the later years of our career more plausible? And I think we touched on a few suggestions there. But yeah, of course, we're part of the problem. But screening is really important as well. That's for sure.
So Sandra asks, do you have any tips for therapists that struggle with keeping up their own enthusiasm in back-to-back rehab sessions? Is the therapist enthusiasm key in pushing patients to achieve their potential?
Before tips, I would just push the notion that we need to be fair to ourselves. Rehab is difficult, and I'll say it, it's more difficult than diagnosis or injections. I've said it, it's recorded. But it's constant, it can be unrelenting. There's significant expectations on you. So first of all, it's normal to feel the toll of those expectations. But when, in terms of things that we can do about it, staying enthusiastic, have a group of people around you who are also enthusiastic about it. But more so than anything, rehab is based on getting to know your patients. And as I said earlier, you're more likely to find it easier to tolerate the toll of the expectations if you have a relationship with your patient, because it's just more fun. I think you need to keep it fun.
I think that's a really good point. And actually, as somebody who works with people who specialize in working with people with communication disabilities and learning disabilities, I really emphasize the whole trying to find common ground and build therapeutic relationships and alliances. And there's some good evidence out there that shows that that's almost as good predictor of positive outcomes as the treatment modality that you choose to use. I think you mentioned that not only does it, give us something to go on from a relationship point of view, but it also helps people who may be anxious. And again, working with people who may have an understanding challenge, that anxiety can be really sort of allayed just by finding some common ground. And then you go from being a therapist, which is therefore a huge empower balance, to a human, a person with common shared goals.
Yeah, you're the person who's really interested in me getting better, and might have a few answers. Having better conversations is a thing that I advocate a lot. Asking better questions because screening questions all around pathology, isn't it? And we're really good at asking those screening questions, but developing our skills on being interested and understanding a person is really powerful. And there's a TED talk. It's one of the top 10 TED talks of all time. It's a lady who's I think she's a TV interviewer from the States, and she talks about 10 tips to have better conversations. I think that's something to consider. Trying to move away from physiotherapy education resources, which can be a little bit bland and a little bit impersonal, to being a better interviewer. I think that's really important. And another tip that I would suggest that I found really beneficial was listening to professional negotiators. I know that might sound a bit odd, but there's a podcast called You Are Not So Smart, by a chap called David McCraney, and they had a professional negotiator on there. And I just listened to it off the cuff, really. But I found it so applicable to our practice, because one of the key challenges I found that I've improved with is people coming in to see you, but they have they're there because they've been referred by their GP, not because they actually want to be there. That's incredibly challenging. I always find it funny that people promote starting the consultation with the question of how can I help. I understand the premise, and I appreciate why people promote that, but I think it comes with, it's a bit of a weighted question, and I can unpack that if you want me to, Alistair. But ultimately, trying to understand what they want from healthcare, not from you, is really important, because you're in a better position to negotiate a care package with them. If you're only asking your patient how they think you can help them, that really narrows down your negotiation tactics in terms of getting someone to engage in the plan that we probably think is going to help them, but they might be dubious as to why, because it goes against common narratives like wear and tear, etc., bending your back and things like that.
I think you did a really nice job of just unpacking it in a very succinct way there, Tom. So perfect. Question from Tim, sort of tongue-in-cheek loaded question. What's your typical loading sets, reps, framework in rehab? You're going to say the typical physio answer is say it depends.
Yeah, really boring question, isn't it? And I know that Tim knows that that's probably going to be my answer to that question as well. It depends. It really depends. But that being said, I will stick my neck out a little bit and say I don't think there's any harm in having a go-to number that you're used to selling to your patient. So early on in my career, I started asking patients what their favorite number was below 10. And then I'd get them to do 3 sets of that thing. And that's just a starting place, because I would give them, I would promote that they manipulate that dosage dependent on how that exercise felt. But I don't know, that's maybe a tip that might help, but it is super complicated.
Like 3 sets of 10 is not optimal, but it's certainly not bad.
It does a lot of things.
A message for that. Yeah,
yeah,
certainly. I think Tim's acknowledged the sort of tongue-in-cheek nature of that one anyway. Jim, yet again, sort of, managing to frame my wordy question much better, and it sort of, comes back to a point earlier on: is the push towards being less specific as a reaction to over-specific modalities part of causing it to be boring?
Is the push towards being less specific as a reaction to over-specific? I don't think I understand the question.
So I think he's sort of asking there, obviously there's lots of push for specificity, and there's almost a push back, sort of another swing of the pendulum to go back towards, we need to be non-specific. And does that mean that it therefore lends itself to being potentially boring?
As in, so are we talking about being less specific is the boring thing, or more specific is the boring thing?
Less specific, I believe, is the boring, the perceived to be boring thing as a response to people being overly specific.
Yeah, I think also it's less aligned to some of the literature, because in physio we're tethered to a lot of S&C principles that are well evidenced, and they've been researched over decades. But how applicable that is to our group of patients is really, really, really questionable. Strength training is really good, but a lot of our patients already have the capacity to do what they want, and maybe just need that permission and guidance with regard to what's sensible with pain. In terms of it being more boring, I don't know if I see that. I think that therapists become uncomfortable with being less specific. I once did a talk on the topic, and a physio said that they wouldn't do that. They wouldn't prescribe less exercise because they would feel uncomfortable. They feel like they're shortchanging their patient. So I think that's the thing. And if I can just go down that rabbit hole a little bit,
if it's quick, yes.
Yeah, what I'd suggest we consider there is making sure that our patients are involved in the conversation around how specific we are, because I agree there's a cultural restriction to being less specific, even though it might be sensible. And the only way we can negate that is by having a conversation with our patient.
Perfect. Perfect. Anybody wants to find you, there is a link in the chat for Tom. But Tom, thank you very much for your time. And we will see you all again. Thank you so much, everybody.
Enjoy your day. Cheers, everyone. Thanks.
Bye. This is where I've lost the exit. There we are. Cheers. And now just we get a couple of seconds and just while it shuts down.